Is the sound okay, Sujna?
Yes, sir. Audio is clear now.
Video is also fine, right?
Yes, sir.
Is the sound okay, Sujna?
Yes, sir. Audio is clear now.
But my video, like I'm not able to see my video on that. Like I'm seeing it being with this thing on the YouTube link. YouTube link, I'm not able to see the video. Hello. Good evening, all. Is my screen visible and is my audio okay? Can somebody reply? Am I audible? Not seeing any reply in the chat. Can I start?
We can start off, sir. Everything is good now.
It's visible. Okay, okay. And I was waiting for somebody to reply from the YouTube. I suppose they're watching it. Regarding the video quality, like, I mean, is the video and audio okay, guys? Can somebody type in the chat box? So I suppose it's okay. So I'm starting with this. So the first question is, which among the following is the most common clinical features of IMN? So the option that was given in the, so like without edu, like I'm just starting because we have already been a bit late. So which among the following is the most common clinical feature in infectious mononucleosis was one of the questions that was asked, which was quite a straightforward question. And the options given were rash, jaundice, splenomegaly, and lymphadenopathy. So as you all know, this is a question from infectious mononucleosis, something that we have discussed. And this is a question that seems to be directly from this table in Harrison, and where the signs and symptoms of infectious mononucleosis has been described. So lymphadenopathy occurs in 95% of the patients with infectious mononucleosis, whereas splenomegaly is seen only 51. Rash is quite uncommon, usually seen when you treat these patients with aminopenicillin, and jaundice is very uncommon. You get transaminitis often, okay, elevated liver enzymes often, but jaundice is very, very uncommon in infectious mononucleosis. So the answer to the question will be lymphadenopathy. So the second question was, Faggot sign is seen which of the following infections? Okay, so you can tell, like, you can also give your options as well, what answers that you think is the correct answer. So Faggot sign is seen in which of the following infection? Is it enteric fever? Is it acute gastroenteritis? Is it tuberculosis, or is it urinary tract infections? So Faggot sign is nothing but dissociation of temperature with the heart rate. So usually it is expected, this is again a line from Harrison, for every 1 degree Celsius increase in the core body temperature, the heart rate typically rises by 15 to 20 beats per minute. And relative bradycardia or Faggot sign is when the patients have a lower heart rate than that is might be expected for a given body temperature. Now, this was first described by Sean Charles Faggot and yellow fever classically, but it has been found to be in various other infections, including enteric fever, tularemia, brucella, coxiella, leptospira, legionella, mycoplasma, etc. And rickettsial infections like rickettsia species causing infections, scrub typhus, babesia, even in diphtheria and malaria also. And as said, viral infection, yellow fever is a classical case in which we get this Faggot sign, that is dissociation of temperature and heart rate. So dengue fever, viral hemorrhagic fever. So there is a number of options that are given. So among these options, enteric fever, acute gastroenteritis, tuberculosis, urinary infection, the best option will be enteric fever. So typhoid fever is something that we have always said is associated with relative bradycardia. Third, typical of nephropathy associated with leptospirosis. So this is again a one-liner. So the options that I've got is loss of magnesium, hypernatremia, and hyperkalemia. So this is again something that is directly taken from Harrison. So acute kidney injury is quite common in leptospirosis, and the typical electrolyte abnormalities include hypokalemia and hyponatremia. But the next line is where our question lies, that is loss of magnesium in the urine is uniquely associated with leptospiral nephropathy. So there is no confusion in this question. The answer is loss of magnesium in urine. So that is typical of leptospiral nephropathy. Now, next question, which of the following drugs has a definite risk of hemolysis in patients with G6PD deficiency? So it's quinine, this is nitrofurantoin, chloramphenicol, gadifloxacin are the options that are given. So again, a straightforward question and also a question from the table in Harrison. Quinine, chloramphenicol, gadifloxacin, not so common, but this is the table again, where you can see among the antimicrobial agents, those drugs which are associated with a definite risk of hemolysis are the drugs including the sulfur drugs, nalidixic acid, nitrofurantoin, and among the antimalarials, again, definite risk. So this is the question, definite risk, antimalarials, trimethoprim, dapsone, and chlorpropanol. So again, no doubt in this question, which among the following drugs has a definite risk of hemolysis in G6PD deficiency? The answer is nitrofurantoin. Fifth question, lava occurrence is caused by, the options are given include Strongyloides circularis, Ancylostoma duodenale, Fasciola hepatica, and Enterobius vermicularis. So another straight question, something straight from Harrison. So migrating lava can elicit a pathognomic serpiginous eruption, which is called as lava currents, which means that a running lava. So below I have shown an image from the New England Journal of Medicine, where you can say they have marked the site of the larvae on the first day, and next day you can see the larvae has moved, okay, from that site. So this is something that is seen in Strongyloides stercoralis infection. So the answer will be Strongyloides stercoralis. I think you all would have made that correct. Something that we learned from our UG days. Which is the next line of treatment for patients with ganciclovir resistant CMV infection is the next question. This is something I believe was discussed in our QRP session, as well as I put it as a slide in our group as well. So this is options are valganciclovir. It's not. Valganciclovir is not the option. Valganciclovir is something a prodrug of ganciclovir, so it cannot be used in patients who have resistance to ganciclovir. Foscarnet and acyclovir. Acyclovir again has no action against CMV. The answer is foscarnet. Again, a question which is directly from Harrison. So this is a drug which is often used in hematopoietic stem cell transplant because ganciclovir is associated with cytopenia. In whatever be the cases, in general, foscarnet is the first choice for infections in patients with ganciclovir resistant CMV. So the answer is foscarnet. So the next question, a patient was treated with community-acquired pneumonia with commonly used drugs a few weeks ago. On review, his liver function values showed elevated alkaline phosphatase. What is the most likely agent that was responsible? So the options given are doxycycline, amoxifloxacin, gadifloxacin, and amoxicillin clavulanate. So there are many drugs which can cause isolated rise in alkaline phosphatase, or what is called as a cholestatic-like blood picture. So among these, antibiotics associated with cholestatic hepatitis include erythromycin and amoxicillin clavulanate, which can cause acute cholestatic hepatitis. This is acute cholestatic hepatitis, and also can cause chronic cholestatic injury and ductopenia. There are other drugs, among which also amoxicillin clavulanate is given. So basically, this patient is treated with community-acquired pneumonia. I'm sure that antibiotics has been given for a few days duration. And in this period, the drugs which can cause an elevated alkaline phosphatase is amoxicillin clavulanate. So the answer is D, amoxicillin clavulanate. Next question, I'm happy that this was also a question that was discussed in our QRP session. A 27-year-old female patient with 2 months history of amenorrhea present with complaints of fever associated with dry gland cells, and a peripheral smear is given. I don't know what the exact image was given, but from what you have told me, and like what has been discussed, it is that it was the smear of a Plasmodium falciparum. So here you can see the smear. There are multiple ring forms, which are small rings. Okay, multiple small rings seen. And this is something typical of Plasmodium falciparum. What is the treatment of choice? Now remember, this is a 27-year-old female who has presented fever associated with dry gland cells of 3 days duration. And what is the treatment of choice? So there is a possibility of pregnancy. So that is what is meant in the question. And the options given are chloroquine, quinine, trimethoprim, and doxycycline. Now here, first thing is to understand that it is a Plasmodium falciparum from the peripheral smear. So that is what is intended. So to identify Plasmodium falciparum, in Plasmodium falciparum, we only see the ring forms, and the ring forms are delicate and small. Small means that less than 1/3 the size of the RBCs. So these are like multiple ring forms can also be seen in a single RBCs, which is typical of Plasmodium falciparum. On the other hand, Plasmodium vivax, the ring forms are larger, okay, larger, and various forms, including amoeboid forms, can be seen in the peripheral sphere. So from the description that as I have received, I think it is a Plasmodium falciparum. And what is to be the drug to be given? So here we have to see whether the patient is pregnant or not, and whether the infection is complicated or not. Now, if the patient is non-pregnant, we know that the treatment of choice is ACTs, that is artemisinin-based combination therapy for uncomplicated falciparum malaria. For uncomplicated falciparum malaria, which pregnancy in first trimester, as our patient is, okay, first trimester. So the treatment is 7 days of quinine and clindamycin, okay. The first trimester, treatment of Plasmodium falciparum malaria in pregnant females, uncomplicated, okay, uncomplicated malaria, it's quinine plus clindamycin. If it is a complicated malaria, whatever be the species, whatever be the trimester of pregnancy, the treatment is parenteral artesunate. So here, how about the options? There is no artesunate. The options given are chloroquine, quinine, trimacquine, and doxycycline. Sorry for the spelling. So the answer here will be quinine. Next, most common transplant infection in the second month of bone marrow transplantation. Options are herpes simplex, varicella zoster, CMV, and EBV. And I'm happy that this was also one of the questions that was discussed, and also one of these questions straightly from a table in Harrison. So hematopoietic stem cell transplant early in the period, that is post-transplant period, the infection, so they have neutropenia, and the infection chances are maximum with gram-negative infections, okay, gram-negative infections as well as gram-positive infection. There's a bacterial infection. This could be line-related, this could be due to the gut-related organism, etc., which can cause bacteremia. And the viral infection that occurs in this particular period of infection is herpes simplex virus, okay, due to like it can cause mucositis and it can cause hepatitis, etc. Second, that is the middle part, that is from the second month onwards. After 1 month, the 1 to 4 months, the maximum risk is with CMV. Okay, the CMV, the risk is maximum from the second month, like that is from first to the 4 months. So CMV is in the second month, continue till 4 to 6 months. And after that, like after 6 months also, like the neutropenia has it has resolved, the maturation of the hematopoietic stem cell transplanted cells occurs, but still you can get some T cell defect. So after 6 months, mostly it is due to a T cell defect. So you can get infections like pneumocystis, nocardia, streptococcus pneumonia. Viral infections that is common at that particular point of time after 6 months include varicella zoster and Epstein-Barr virus. And also, like T cell, there is also limited antibody protection. So you can get infection with encapsulated bacteria like streptococcus pneumonia, Haemophilus influenza, and Neisseria. So coming to the question, the most common transplant infection in the second month of bone marrow transplant is cytomegalovirus. So which among the following is a ligand for toll-like receptor 5? So there was another question. So the options, I am not sure of the options, but I have given these are the options. Like these are like only I know that flagellin was one of the options. Again, a question which is straight from Harrison. This table which shows these are pattern recognizing receptors, PRR. So this is a very important topic. So the pattern recognizing receptors, among which the toll-like receptors is very important. Straight question from the table. TLR5 is flagellin. Okay, flagellin. I think other important questions that can be asked include lipoprotein, LPS, that is like lipopolysaccharides receptor is toll-like receptor 4, as well as CpG DNA toll-like receptor 9. In any way, our answer at this particular point of time is flagellin, that is TLR5 is flagellin, no doubt in that. Next is, which among the following is seen in the histology of HIV-associated nephropathy? So the options include MPGN, FHGS, membranous nephropathy, and IgA nephropathy. Somehow I am not able to see any like interactions. I don't know whether like there is an issue with typing or like I'm not seeing it. Anyways, which among the following is seen in histology of HIV-associated nephropathy? Is MPGN, FSGS, membranous nephropathy, or IgA nephropathy? These are the question. I'm sure only about this option was there. FSGS is there. Rest of the option I'm not very sure. Anyway, the answer is focal segmental glomerulosclerosis. So HIV-associated nephropathy, histologically, it 80% of the patient has focal segmental glomerulosclerosis and their presence with proteinuria. And 20%, like around 10 to 15% of patients can have mesangial proliferative nephropathy. So this is again a straight question from Harrison. Most of the 90% of the questions in infectious disease this time were straight questions from Harrison. This is the histological appearance. You can see this collapsed, okay? This collapsed glomeruli you can see. So this is if you be more specific, the typical nephropathy in HIV is collapsing variant of focal segmental glomerulosclerosis. Okay, collapsing variant of focal segmental glomerulosclerosis. So I hope you have made it correct. Next is AV block is the least common in which of the following infections? The questions option includes Chagas disease, Lyme's disease, toxoplasmosis, and HIV. I'm not sure about this option C. Some of the students have told it to be diphtheria. In whatever be the cases, the answer for this question will be HIV. All the other diseases like Chagas disease, Lyme's disease, toxoplasmosis can cause cardiac infiltration and cause AV block. Okay, AV block can be seen in all of these infections. Again, straight from Harrison, page number 1882, Lyme carditis, bacterial endocarditis with perivalvular abscess, viral myocarditis, Chagas disease, toxoplasmosis, all of them are associated with AV block. And HIV plus HIV sometimes can cause, like opportunistic infections can occur and cause AV block can occur. Per se, AV block, HIV is not considered as a main cause. So the answer in that question will be HIV. So diphtheria, again, diphtheria can also cause various cardiac arrhythmias and heart blocks. So diphtheria was option. So diphtheria definitely can cause heart blocks. The answer will be HIV. Question number 13. Which of the following is the schedule for accelerated hepatitis B vaccination? Is another question. So there are options 0721 followed by 6 months, 0721 followed by 12 months, 01 2 months followed by 6 months, and 01 1 month. So this is a controversial question. I admit that I am not very sure what the examiner is intended with this particular question. So actually this depends upon the vaccine that you're using. So if you're using Engerix B, a schedule that is given is like 0, 1 month, 2 months, and then 1 year. Then you have another schedule where you combine hepatitis A and B vaccine, that is 0, 1, 7, like 0, 7, that is 1 week, 0, 7. Then you have 1 month, 21 to 28, and 1 year. So this is this option. So it can be 0, 7, 21 to 28, that is 1 month, and 1 year. So this is something that we also have been routinely doing in transplant patients, also which has been recommended, even without hepatitis A also. Then you have another new vaccine, which is called as Heplisav, which is a CpG DNA hepatitis B vaccine, which is given as 2 doses, 0 and 1 month. So which option really they wanted, I'm not very sure. I would have gone by 0, 7, 21, followed by 12 months. I am sure there are differences in opinion. I agree with that. There are like some confusion in this particular question. Question number 14, a child presents with following skin lesions, and which of the following statement is not correct? So basically the skin lesions was typical of varicella, and the options were varicella disease is mild in vaccinated compared to unvaccinated. Varicella disease is mild in unvaccinated compared to vaccinated. Neurological complications in varicella is rare, and varicella lesions are atypical in vaccinated children. The answer is like varicella vaccination is mild in vaccinated. Okay, it is mild in vaccinated compared to the unvaccinated. And option number B is not correct. It is not mild in unvaccinated. Okay, so this is severe if you don't have the vaccine. So that is something that is very clear. I'm not sure about the option, but if these are the options, option number B seems to be the right answer. Neurological options with varicella vaccines are less common, and varicella lesions causes atypical infections in vaccinated children. Now, this is something called as breakthrough varicella. So most documented cases of varicella in vaccinated children are actually mild. And in vaccinated children, atypical lesions are seen. So that is, fever may not be seen in these patients, and rash may be maculopapular rather than vesicular. A number of lesions are so less. So basically, these lesions are atypical. So that is also correct. So the only wrong options is that varicella disease is mild in unvaccinated compared to vaccinated. So that is the correct answer. So question number 15, which among the following causes malaria meningitis? Again, I'm happy that we discussed this when we discussed HSV. So the options include HSV, VZV, enterovirus, and EBV. So you know that HSV, among the herpes virus, HSV2 is the most common cause of meningitis, whereas HSV1 is the most common cause of encephalitis. And molecular meningitis is what is recurrent lymphocytic meningitis, okay? Recurrent lymphocytic meningitis, and this is HSV2. So the etiological agent for malarial meningitis is HSV2. The option given did not specifically ask you to choose between HSV1 and 2 even. So basically, what is malarial meningitis? And malarial meningitis is recurrent lymphocytic meningitis. You also see bizarre cells, okay, which irregular nucleus, okay, irregular nucleus, and these are called as malarial cells, which is typical in HSV infection. Next question is, which of the following has the least association with hepatitis C infection? Option given are Hodgkin's lymphoma, monoclonal gammopathy, porphyria cutanea tarda, and Zika syndrome. So again, this seems to be a question which is directly from Harrison. So this is given in Harrison, the extrahepatic manifestation of hepatitis C, including essential mixed cryoglobulinemia, EMC, which can cause vasculitis, membranoproliferative glomerulonephritis, B-cell lymphoma. Harrison has mentioned it as only B-cell lymphoma, but it is non-Hodgkin's lymphoma. Monoclonal gammopathy can be seen. Sjogren's syndrome and associated Zika symptoms can occur. Lichen planus is seen. Porphyria cutanea tarda is seen. So the option here will be, which of the following is the least association with hepatitis C infection? The answer will be Hodgkin's lymphoma, because it's non-Hodgkin's lymphoma, which is more common with patients with hepatitis C. Question number 17, which among the following is the least common cell in tuberculous pleural effusion? The option included lymphocytes, neutrophils, monocytes, and mesothelial cells. Again, you will not have any confusion between lymphocyte, and you're sure that lymphocytes is the most predominant cell which is seen in tuberculous pleural effusion. Neutrophils can be seen especially in the early part of the disease. Again, monocyte, like if there are lymphocytes and neutrophils, some amount of monocytes can be seen. Well, what the question, the person who put the question intended is that, like, whether you have read Harrison line by line, because this is straight from Harrison. Neutrophil may predominate in the early stage, but lymphocytic predominance is a typical finding in the pleural effusion. And then comes the statement, mesothelial cells are generally rare or absent. Okay, so mesothelial cells are generally rare or absent. So that is what the examiner possibly was looking at. So answer is mesothelial cells. Question number 18, Barnes-Worth syndrome is associated with, options included Borrelia recurrentis, Borrelia burgdorferi, actinomyces, and treponema. So these are the answer, like, options that I believe, like, it was provided to me. So among these, again, Barnes-Worth syndrome is what is called as Meningo Polyneuritis. Okay, Barnes-Worth syndrome is Meningo Polyneuritis. So basically, what happens is that there is painful radiculopathy. Okay, painful radiculopathy associated with CSF pleocytosis. Painful radiculopathy associated with CSF, there will be increase in the cells in the CSF. And this occurs in Lyme disease, which is caused by Borrelia burgdorferi. So the answer will be here, Borrelia burgdorferi. So that is question number 18. Question number 19, which among the following is a false statement regarding leptospirosis? Not sure about the options. I'm only I know the, like, answer is like, no confusion in that. I suppose these are the options. It's zoonosis, definitely it's a zoonosis. Leptospiral infection leads to severe infection in majority of the affected individuals. And it can cause hepatic and renal dysfunction. You know that is correct. The disease is common in tropical areas, so it's correct. I suppose this is an easy question. Leptospirosis infection in most individuals is a mild disease. Again, one liner from Harrison. Although leptospirosis is potentially fatal disease with bleeding and multi-organ failure, majority of cases are thought to be relatively mild, presenting a sudden onset of febrile illness, something that we also see. Only those patients are really sick. Like, these are not too many patients. Very less number of patients actually go into the characteristic wheel syndrome associated with AKI, jaundice, and pulmonary hemorrhage. Most of the infections are mild, so this is something that we have to be knowing. And the intention is again to test your knowledge in Harrison. So whether you have read Harrison or not, factual questions. Most of the questions this time were factual questions. One-liners from Harrison. So, 20th question is a patient presents with complaints of diplopia, dysphagia, and dysarthria followed by weakness in both limbs, and 12 hours later they develop respiratory distress and requiring mechanical ventilation. So, what is the possible etiology? So, the patient presents with complaints of diplopia, dysphagia, and dysarthria followed by weakness in the lower lip. 12 hours later, the patient developed respiratory distress and required mechanical ventilation. What is the possible etiology? So the option given included tetanus, strychnine poisoning, botulism, and diphtheria. You know that tetanus and strychnine predominantly causes spasticity, okay, like spastic kind of in the limbs. And whatever given is a typical cranial nerve palsy, including extraocular muscles and the phalangeal muscles. So here the option answer definitely is botulism. There is no confusion in the answer. Botulism is definitely the answer. This is a straight question from Harrison again. Typically it is taken from Harrison to put in the question there. Botulism produces a syndrome characterized by bilateral cranial palsies that may be followed by symmetric descending flaccid paralysis, and which can lead on to respiratory arrest. So next question you may ask me is that why is it not diphtheria? So diphtheria is a more indolent cause. It's not like the patient will develop diphtheria in 12 hours, they develop respiratory failure. So the polyneuropathy in diphtheria is slower. It take 3 to 5 weeks after the onset of diphtheria, and it's a slow indolent course. And it can involve the muscles of the mouth and neck, and it can even cause dysphonia, dysphagia, and cranial nerve paresthesias, and lead on to respiratory weakness as well. But the point is that this indolent course, the sudden onset of this disease and the rapid progression is suggestive of botulism. No confusion in that as well. So next question. A patient known case of diabetes mellitus and recurrent urinary tract infection present with complaints of fever. Renal biopsy is done, which shows periodic acid shift, PAS positive, forming macrophages with multinucleated giant cells. So PAS is a stain, as you all know. And what is the possible etiologies? The options that were given included xanthogranulomatous pyelonephritis, malakoplakia, renal tuberculosis, and E. coli infection. So basically, this is a chronic infection, okay, like recurrent infection. And from the recurrent infection, there are two possibilities. It can be xanthogranulomatous pyelonephritis or malakoplakia. So both are options, but the clinching the diagnosis is PAS positivity. Both of these diseases can occur in the kidneys. Malakoplakia is more commonly seen in the bladder, but it can involve the kidneys also. So this is in fact associated with recurrent infections, especially E. coli, and the debris that like the macrophages take in. Okay, so when there is an inflammation, macrophages come up. The debris of these bacteria are taken up by the macrophages and they stain positive by PAS in malakoplakia. So the answer is malakoplakia. So histologically, in malakoplakia, there will be a foamy macrophages which are PAS positive, okay, which can be PAS positive, and they also contains laminated mineralized concretions, so laminated calcium depositions, which are called as Michaelis-Guttman bodies, okay, Michaelis-Guttman bodies. Xanthogranulomatous pyelonephritis again occur in patients with chronic urinary tract obstruction, especially in the setting of obstruction with stones. Pathologically, they are characterized by yellow coloration and infiltration with lipid-laden macrophages. Okay, lipid-laden macrophages. So this is image of malakoplakia. This is malakoplakia. As you can see, this is the stain is PAS. Okay, PAS stain, and it is positive in malakoplakia. On the other hand, on this side, it is xanthogranulomatous pyelonephritis. You can see foamy macrophages. And which are PAS negative. So the answer here will be malakoplakia. So answer is malakoplakia. The other options I'm not very sure of. Xanthogranulomatous pyelonephritis and malakoplakia was there, and answer is malakoplakia. 72nd question: an HBs positive patient is planned for rituximab. How long the antiviral prophylaxis should be given in this patient? So the antiviral prophylaxis HBs positive. So what is like basically they're giving the treatment of hepatitis B only. So how long it should be given? It should be stopped immediately after rituximab. Should you give it for 3 to 6 months, 6 to 12 months, or lifelong antiviral is the question. So this seems to be a question directly taken from Schlesinger. So like the duration of antiviral treatment for hepatitis B after B cell depleting agent. Okay, rituximab is an anti-CD20 molecule. So the anti-CD20 molecule rituximab has to be given for a duration of 12 months post giving rituximab if they are HBsAg positive. The exact answer here will be 12 months. Among the options, the best option is 6 to 12 months. Question number 23, HIV patient on irregular treatment present with complaints of confusion and delirium. He was diagnosed as stage 3 AIDS. Later, he developed dementia due to progression of the disease. What is the diagnosis? So the option given included progressive multifocal leukoencephalopathy, HSV infection, acute cryptococcal infection, and toxoplasmosis. So PML, HSV, cryptococcus, and toxoplasmosis. Basically, they're telling it is predominantly confusion and delirium. Now, in HIV, HSV is not a common cause of CNS infection, can occur but rare. Cryptococcal infection can occur, usually presents a subacute meningitis, known as confusion delirium, like it's progressing to dementia. So that is not something that we usually see. So here the answer is progressive multifocal leukoencephalopathy. It's encephalopathy which is caused by JC virus. Now the JC virus, this particular disease presents with visual field defects. That is the most common presentation, homonymous hemianopia, mental impairment, and weakness. But like 38% of the patient can develop dementia, confusion, and personality changes. So answer will be progressive multifocal leukoencephalopathy. Again, something that I have discussed. Even if I haven't discussed, most of you would have made this right. I don't think there was a confusion in this particular question. 24th question. 50-year-old male patient presented with complaints of fever and cough. Respiratory rate was 18 per minute. BP was 110/80. Blood urea was normal. I don't know what the exact value that was given. A diagnosis of community-acquired pneumonia was made. In what setting will you treat the patient? So it's outpatient, it's inpatient, or an ICU care. So basically what they're testing is your knowledge about the curve 65 scoring. In Harrison, it is there. So each these, that is curve 65 for C, U, R, B, and H more than 65, 1 point is given in community acquired pneumonia. So C is for confusion, U is for urea more than 20 milligrams per deciliter, R is for respiratory rate more than 30 breaths per minute, B is for systolic BP less than 90, and 65 is H is more than 65. The curve score is 0. All the curve score is 1 in patients more than 65. That is, they have a score 1 just because they are more than 65. These patients can be treated in outpatient basis. So our patient did not have any of the scoring parameters, like respiratory rate was less than 30, the BP was more than 90, urea was normal, his age is 50. So definitely this patient has to be treated on an outpatient basis. And the last question, indication for steroids in PC pneumonia. Again, I'm happy that this was also discussed in the QRP session. CD4 less than 100, PO2 less than 70, non-responding treatment for 5 days, high-grade fever. So what is the indication for steroid in PCP pneumonia? We have discussed this in detail. Again, we have the NACO guidelines, which says that steroids are indicated when PaO2, that is partial pressure of oxygen, is less than 70 millimeters of mercury and room air, or the alveolar arterial, this is wrong, alveolar arterial O2 gradient is more than 35. So remember both of this, and like if you have to write future exams, let it not be the case. PaO2 less than 70 millimeters of mercury in room air, or if the alveolar arterial O2 gradient is more than 35, you have to give prednisolone, usually given as 40 milligram BD for 5 days, 40 OD for 5 days, followed by 20 OD for 11 days, along with Cetran, that is trimethoprim sulfamethoxazole. So that is the treatment for PCP. Indication for the treatment of indication for steroids is a PaO2 less than 70. So there's no doubt in that question. So altogether, thus we had 25 questions in infectious diseases. This is what I could collect. My answers are predominantly based on the questions that you had provided to me. So I thank all the students who discussed these questions with me. And if you look at the questions, most of these questions were one-liners, fact-based questions. Like if you had read these, you would answer. Otherwise, you can go wrong. So infectious disease question, I believe most of them were moderately, like maybe slightly on the tougher side, but a moderate kind of paper, I would say. And I am happy that at least a good number of questions were in fact discussed in the QRP session. So this is basically a session in which we just discuss the answers. We have a detailed discussion of all these 25 questions that will be uploaded in the DocTutorials app. Please do follow. And that's all from me. Thank you. I'll just check the questions. I couldn't find any questions from these, but so. Yeah, somehow like there was some delay in the question being transmitted to my mobile. Anyway, I am happy that you were answering. I couldn't find that. I'm sorry that I couldn't make it a interactive session because I couldn't find these answers coming up. Thanks a lot for watching. Thank you. Yes.